So our first speaker today is Dr. Camilla Hoyos. Camilla is an NHMRC ARC Dementia Research Fellow in the School of Psychology and the BMC. She's also a research affiliate at the Sleep and Biochronology Center at the Woolcock. And she investigates how sleep problems impact on health. And her talk today is on the effect of treating sleep apnea on cognition in older adults at risk of dementia. Thanks very much, Camilla.
Thank you. Thank you for having me today. I'm very excited to be here. So just to start off with, I'm going to be talking about obstructive sleep apnea and whether or not treatment can slow cognition and decline in older adults at risk of dementia. So I'm sure everyone knows about sleep apnea, so just a brief introduction. It's characterised by recurrent closures of the upper airway during sleep, leading to two hallmarks of the condition. Firstly, sleep fragmentation. So there's usually a reduction in that slow wave sleep that we get, the restorative sleep, as well as the closures leading to dips in our blood oxygen, which results in intermittent hypoxia. So it's very common, up to 1 billion people are estimated worldwide to be living with at least mild sleep apnea. And what we're learning about now is that a lot of these people are older adults, with estimates of 50% and in some populations up to 90% of older adults living with sleep apnea. So there are many consequences and or health consequences, and a lot have been focused on the cardiovascular and metabolic sides, as well as impaired neurobehavioural function. And this includes increased risk of motor vehicle accidents, workplace incidents, and just reduced productivity. However, a real big focus at the moment is whether sleep apnea is also independently associated with neurodegeneration, memory decline, and incident dementia. And epidemiological research just show sleep apnea is associated with a 26% increased risk of incident mild cognitive impairment and dementia. The proposed mechanisms for this, there's quite a few of them. Neuroinflammation and oxidative stress and neurovascular changes are linked to the intermittent hypoxia. And then there is this association of the sleep fragmentation causing risk of increased beta amyloid accumulation, because the clearance kind of process that happens overnight is very much in slow wave sleep. And in the last couple of weeks, our colleagues in Monash have shown, using PET imaging, that there is greater beta amyloid accumulation in people living with sleep apnea compared to controls. So what about the effect of treatment, particularly in older adults who are at risk for dementia, so people living with mild cognitive impairment in particular? So there's very little research on this at the moment, and we can see here this lady is using continuous positive airway pressure, or CPAP, which is the first line treatment for sleep apnea. And it's putting airway down the upper airway so that it is splintered open and stopping those recurrent obstructions from occurring. So the research current to date is all observational, but it is suggesting that there are improvements in the short term and in the longer term in people living with mild cognitive impairment. But we do need randomised controlled trials to very much tease apart what is because of the CPAP itself versus other lifestyle changes that people might be making. So this is where we come in with our pilot study, which was started a few years ago now by Professor Sharon Naismith and Professor Ronald Grunstein. And this is a randomised controlled crossover trial, which is comparing 3 months of CPAP treatment versus no treatment with a 2-week washout in between. So we recruited our participants from the Healthy Brain Ageing program at the Brain and Mind Centre, and they also had an overnight polysomnography at the Woolcock Institute so that we could find out if they had sleep apnea or not. We were looking at people who were aged 50 to 80 who had mild cognitive impairment as well as moderate sleep apnea. A lot of exclusions which are common to these types of randomised controlled trials. What we were looking at in this for our primary outcomes were the cognitive domains around executive functioning and processing speed. And these were chosen because literature had shown that in like more traditional samples of middle age, people with sleep apnea, this is what was impaired. We were, of course, looking at people with mild cognitive impairment and who were older, so we were also interested in memory and learning, and we also looked at the RAVOLT. We've also got some subjective sleep quality and subjective depressive symptoms and daytime sleepiness as measured by the Epworth Sleepiness Scale. So we randomised 29 participants. We completed 22 people, but we've got 26 people being analysed in our analysis. So we had people who were in the middle of our age range. 50% were men. They're overweight and have a moderate, as we expect, but moderate to severe type of condition. I'll just point you to the CPAP use that they had across the 3-month period. So that is 3.2 hours across what we would assume would be an 8-hour nightly sleep. And this might seem very low, and I guess it is, but that is what we see in basically normal CPAP clinical trials. We're seeing 10 people who, you know, might use their machine well, as we have this arbitrary cutoff of 4 hours, but there is a big range, and we know that that is what is also happening in the real world. So our results of our primary outcomes in that executive functioning space, we have mean CPAP on one side, no mean CPAP, mean no CPAP on the other side, and then the individual changes. We're seeing no effects of CPAP on these outcomes. When we looked at the memory outcomes, however, we did see that with CPAP we saw more, better learning and memory retention, and we can see that these are moderate effect sizes, remembering that this is a pilot study that we were trying to gather how we could do this and inform a larger study. So thinking about these results, what about the primary outcome of future studies? Should we be starting to think about this and changing it a little bit in these older populations? Our CPAP use, as we know, was low, similar to other studies. So do we need to think about more real-world interventions for sleep apnea? And then also about diagnosing sleep apnea. And it's very hard to get everyone who, because we're recruiting from healthy brain ageing programs or memory clinics to do overnight sleep studies. So that's where we've come to for our new study, which is an NHMRC funded study looking at reducing sleep apnea for the prevention of dementia. This is a feasibility trial, and we're bringing together a national and international team of people who are interested in and researching sleep apnea and cognitive decline. We need those skill sets, particularly in sleep apnea, because the interventions can be difficult, and we don't have essentially a pill to switch off the disease. We have to use different types of usually device-based interventions. So from this study, what we're hoping to do is look at the prevalence of people, how many people can we get what we want from these clinics, the acceptability of being randomised. It's a 2-year study, and we want to know if people will take on no treatment for their sleep apnea, even though it's newly diagnosed. Are we treating their disease? So rather than just totting up how many hours a night they're using their CPAP, is it actually treating their hypoxic burden? Is our intervention tolerable? And we're also getting effect sizes and mechanistic factors. So we will be recruiting and randomising 180 people, and our intervention is a little bit different than normal, where maybe one treatment of sleep apnea is chosen and that is what the intervention is. We have what we're calling a toolkit, and it's basically meant to be very pragmatic and what the sleep doctors clinically may have at their disposal for sleep apnea treatment. It won't be everything that is available, but it's those main things, including CPAP, mandibular advancement splints, positional therapy. So a lot of people have their condition on their back and you can turn them on their side using devices, as well as oxygen therapy. And this will be very personalised and led by the sleep physicians. This will also come with a 6-month behavioural intervention as well. In our control arm, they will all be referred back to the GP. They'll get 10 emails supporting them during the 6 months, just getting some information so that they're engaged. But there is no sleep apnea treatment restrictions. So if the GP sends them to a sleep doctor or to the CPAP shop down the street and they start treatment, we will just be recording that to understand how that might impact our larger definitive trial. And just very quickly, we are implementing some screening devices in here for sleep apnea so that we're able to kind of get through a lot of participants, because we do believe we're going to be screening 1,200 participants to get our 180. And we need something that's scalable for these larger trials that we want to do in the future. This is an oximeter that sits on your finger, and that's what will do the bulk of the screening. And then actually measuring sleep apnea and the hypoxic burden during the trial will be this other at-home device, which is called a watch pack. And we'll get some nice other indices from that. So thank you very much for listening today, and thank you to everybody that's been involved in the original pilot study and now reshaped moving forward.
Hi, thanks very much, Camilla. It's a fantastic talk. It's great to think there's something treatable in dementia now. As a lot of us notice, compliance with the CPAP machine is really hard, and it's nice to see that things like mandibular advancement devices are in the new trial. Do the mandibular advancement devices work?
For sleep apnea treatment? Yes, definitely. And they haven't been trialled with an outcomes in terms of cognition in our populations, but they have also been looked at in their comparative and effectiveness in other outcomes, including blood pressure and things like that. So yes, again, very personalised. So there are reasons why you might not be able to use a mandibular splint in terms of teeth. So we have to work with a dentist. A dentist always fits that, and they're made for them. And then also it might be about the severity of the condition. So if someone has a very severe condition of sleep apnea, maybe it might be not right for them. But again, that's why we need to do it in a more personalised rather than one-size-fits-all approach.
Fantastic. And we've got a question here from Alex Perez, who's asking, could you please explain what you meant by behavioural intervention?
Oh, yes. So this has been designed by our team, Lauren Mazowski and Sharon Naismith, and this will be telling them about, well, it's around sleep apnea and their devices as well. So to help them, I guess, it's getting over those barriers and understanding goal setting and all those types of things to try and help them be able to comply with whatever treatment they're having, but also to learn more about healthy brain aging as well. So it's like a complete package.
Fantastic. Thanks very much, Camilla.